Good afternoon. We're going to get started with our session on health financing. I hope everyone had a light lunch because this is a very important session on a very important topic. And we're going to be dealing with the crucial issue of health financing, which itself poses very interesting challenges in terms of measurement, in terms of the development of metrics, and also in evaluating the effectiveness of different arrangements in the financing sphere. Also, as the world embraces the cause of universal health coverage, clearly finding ways in which to make health systems be financed in a way that's both fair and sustainable has become a major topic in the global agenda. So this afternoon we are going to be treated to 5 very interesting presentations on 5 young researchers. It's a good example of the sort of approach that the whole conference has taken of young people presenting and being selected for submitting and then being selected for presentation here. Let me quickly just say a word about each of the panelists. You have more information on your materials, and then we will proceed in the order in which they are seated. They know that they each have 12 minutes, and that will assure that we have at the end a good 20 minutes for questions and answers. I would ask that you hold your questions until we have heard the 5 presentations. So in order, we will be starting with Joseph Dieleman, who's a research assistant here at the University of Washington, and who will be talking about measuring the displacement and replacement of government health expenditures, a panel analysis. I think this will be very interesting. Then Alan Diener, who's a consultant at the Organization for Economic Cooperation and Development, will be talking about deriving expenditures by disease under the Systems of Health Systems Account 2011 framework, a systematic analysis. He will be followed by Rouselle Lavado, who is a postgraduate fellow here at the Institute for Health Metrics and Evaluation, and she'll be talking about a systematic analysis of national health accounts from 1990 to 2010. And then Yuki Murakami, who's a health economist and a policy analyst, also at the Organization for Economic Cooperation and Development in Paris. We'll be talking about linking aid statistics and national health accounts for effective resource tracking. And finally, Gabriela Flores, who's a research fellow at the University of Lausanne, and also she's also at Erasmus University, will be speaking about catastrophic medical expenditure risk. Once we hear from each of them, we will have the opportunity to ask questions. So let me then ask first Joseph Dieleman to make his presentation.
Do I need to do something? There we go. There you go. Awesome. I probably could give it without slides, but it wouldn't be as exciting. So thank you for that introduction. It's a pleasure to be here today. I'm going to be presenting ongoing work that I'm doing with Mike Hanlon, who's also at the Institute for Health Metrics and Evaluation. I found when introducing this topic to people, it's very easy to get confused with the acronyms and especially some of the asymmetries that I'm going to be discussing today. So I'm going to introduce this topic today by describing and talking about 2 key variables, 1 important relationship, and one important reality that I think makes this more complex and more interesting. So starting by describing the 2 variables that are most interesting and most important to this analysis. And those are government health expenditure as source and development assistance for health channeled to the government. And these 2 variables combined add up to make total government expenditure. So what they have in common is that the government is spending these resources specifically on the health sector. What distinguishes these 2 variables is where the resources are actually coming from. So government health expenditure as source is internal resources. They're resources that a government raises internally via taxes, a social security system, something like that. where development assistance, of course, is coming from abroad. It's external, it's possibly channeled through a bilateral aid organization or an NGO, but eventually finds its way to the government, and the government spends that money specifically for health projects. So then the relationship that I'm going to be talking about is how these two variables are interacting. And specifically, I'm going to be looking at how development assistance for health channeled to the government impacts government health expenditure as source. And there's been some research on this already. There's research in the economics literature, but also research in the health literature that has kind of come to a pretty stable conclusion that increases in development assistance lead to decreases in domestic government health expenditure. So the idea would be that there's some sort of displacement or there's some crowding out. And since this is a very multidisciplinary literature, lots of people from different backgrounds use different words to describe the exact same thing. So I'm going to use the term displacement, the idea that government health expenditure is being displaced. But that's the exact same thing as saying government health expenditure is substituted out, that it's crowded out, or the same thing would be to say that aid is less than fully additional, that it's sub-additional, or that it's fungible, just meaning that it can be easily transferred across sectors. So I said that there's two variables, one relationship, and one reality that I'm going to be discussing. The reality is that, and I think this is pretty well known at this point, is that after 2 decades of a pretty dramatic scale-up, development assistance for health seems to be leveling off. And of course, it'll take several more years to be able to state this as a clear fact, but the last several years of data tracked by the Institute for Health Metrics and Evaluation suggests that after a lot of growth, there's kind of some stagnation. And this is important to this conversation because the relationship that I described just a second ago has been primarily discussed in an age of increasing development assistance. So the question has always been asked, if there's an increase in development assistance, what happens to government health expenditure? The question that is important now, and I think has always been important, but we haven't necessarily been asking it, is what happens when development assistance actually decreases? Do we see a substitution back of government health expenditure? So the language that I'm going to use is there's displacement when development assistance comes in. Is there replacement when development assistance goes out? And to make this even more crystal clear, I have 3 real simple schematics that I'm going to look at. So this is just a hypothetical example, and on my y-axis, we have total government health expenditure. So you can see for this hypothetical country in year 1, all of their resources were raised internally. It's all domestic resources. But year 2, there's an aid shock. There's an increase in development assistance for health channeled to the government. And then in year 3, that money is taken away. So there's actually a reduction in development assistance. It's a 1-year thing. And what we see in this picture is that there's no displacement. So there's an increase in development assistance, and that increase is the exact same as the increase in total government health expenditure. Now, of course, this can be contrasted with what many people have kind of agreed is probably the case, that there's an increase in development assistance, and a rational government receives these resources and essentially reallocates some. So because the development assistance for health is specifically channeled to the government will take some of their own resources, the government health expenditure as source, and send it to other sectors, education, military, and so forth. And then, most importantly, what we see so far, or what has been kind of the conventional expectation, is that once that aid is taken away, the government health expenditure will bounce back up. The government will reallocate resources from wherever they sent them temporarily to and send it back into the health sector. And what I'm going to be questioning today is, does that replacement really exist? So my last schematic right here shows the exact same picture. We have development assistance coming in year 2. It's taken away in year 3. And what's important to recognize here is that there's not the same amount of replacement. So displacement takes place in year 2, but when development assistance goes away, this picture shows a lack of replacement. So to summarize all 3 of them, case 1 shows no displacement and consequently no replacement. Case 2 assumes, which I think has been the convention, that displacement and replacement are the exact same thing. And then in case 3, there's a question that maybe displacement and replacement don't equal each other. And the reason case 3 is really, really important is because you can see that year 1 and year 3 in case 3 actually differ. And essentially, the replacement leads to a financing gap when development assistance is taken away, or potentially. And that's really going to be what I'm talking about today. So my objective number one is that I'm going to be measuring displacement and replacement simultaneously and not necessarily assuming that they're identical. And then number two, I'm going to essentially estimate the consequences of that displacement without replacement. So how do I do that? I use a linear regression. My left-hand side variable in my linear regression is government health expenditure as source. And all of my observations, all of my data are at the country year level. And then on the right-hand side, I have a number of variables, but the two variables that I'm most interested in are development assistance for health channeled to the government, DAHG, and then a variable that I call DAHG minus. And that's just a variable that I've constructed, and it's essentially the interaction of development assistance for health channeled to the government and an indicator that shows that DAHG is decreasing. So if, on the other hand, DAHG is increasing or staying the same, then this DAHG minus variable is just going to enter as a 0. But in the occasions when development assistance for health channel of the government is going down, that will show up as the actual variable. And that's really important because it allows me to separately measure the displacement and replacement effects. So beta 1, my estimate of beta 1 is the displacement rate, what happens when development assistance goes up. And then the sum of beta 1 and beta 1 spread is going to be the replacement rate, what happens when development assistance goes down. And then I include a number of other covariates that are pretty standard in this literature. So in order to estimate this equation, I put together a panel of 132 countries from 16 years. I collect my data primarily from the World Health Organization and the Institute for Health Metrics and Evaluation. And then to estimate this equation, there's two pieces that make it a little bit cumbersome or difficult that I need to consider. I have a cross-panel heterogeneity. Essentially, that's country-level unobserved heterogeneity. And I can control a fixed effect to control for that. And then I also have within-panel autocorrelation. Essentially, my residuals are autocorrelated through time. So to control for both of these things simultaneously, I use difference general method moments estimation. My estimation shows that the displacement rate is minus 0.63. And this is statistically significant at the 99% confidence level. So what this means is a $1 increase in development assistance leads to a 63-cent decrease in government health expenditure. Or in other words, that says that 37 cents of every $1 of development assistance is fully additional. In comparison to the replacement rate, we find that the replacement rate is only minus 0.26. Or a $1 decrease in development assistance leads to an increase of government health expenditure that's only a little bit above a quarter. And this is not statistically different than 0. And now when I compare the two rates, the displacement rate and the replacement rate, I find that they're statistically not equal, or I can reject that they are equal, essentially, with a confidence level of 94%. So in summary, what I'm finding is that an increase in development assistance for health channeled to the government leads to a decrease in government health expenditure. But at the same time, a decrease in development assistance for health channeled to the government doesn't necessarily have an effect on government health expenditure. So to visualize these results, I put together an example. This is essentially the average across all the low-income countries in my data set. And you see that the total government health expenditure, measured in the green line, is about $30 for this country across a 5-year span. And then development assistance is in red and government health expenditure as source. The domestic stuff is in blue. You add the blue and the red and you get the green. And you can see the blue and the green are spaced evenly because development assistance in this example is forced to be constant. So across all 5 years, the red line is set at right about $4. Now I compare this to a development assistance series that has a 1-year shock, a 1-year increase in development assistance in 2002. So that shock leads to a couple of important effects. First, we see that government health expenditure as source, the blue line, goes down. That's essentially the displacement. Still, we see that the net effect in 2012 is positive. The green line goes up. So total government health expenditure is increased because of this aid, despite the displacement. The displacement isn't full, so there's still some increase. On the other hand, if we turn to 2003, after the shock has ended and development assistance has returned to what I had it at initially, then we see that government health expenditure doesn't bounce up enough. Essentially, the replacement rate isn't sufficient to take or to kind of correct for the displacement that took place the year before. And as a consequence, we see total government health expenditure that's lower. And so after a one-year shock, a one-year increase in total government health expenditure, there's this gap, this financing hole that persists over the next several years. Another way to measure this would be to aggregate different scenarios under a counterfactual. So I've looked here at two different counterfactual. The first bar here says, what if recipient countries did no displacement? So the displacement coefficient was set to 0, and there was no displacement taking place. What I estimate using this equation is that I would have $52 billion that would remain in the government health expenditure across all 132 countries in 16 years. The second counterfactual that I look at is what if donor countries dispersed their development assistance for health to the government in a monotonically increasing fashion. And what I mean by that is that it's always increasing or constant, but it's never decreasing. And the reason this is an important scenario to consider is because it's decreasing that essentially leads to this problem when there's not replacement. So when there's a lack of replacement, we create this gap. So by smoothly distributing or dispersing development assistance, we don't have the big displacement followed by little replacement problem. And in this scenario, I find that there'd be $23 billion left or additional resources in the government health sectors across these 132 countries. So in conclusion, I've asked kind of three important questions, and the qualitative answers are this. First question says, does displacement exist? And I found that statistically significant evidence that says it does. Yes, there is displacement. The second question says, is the replacement rate the same as the displacement rate? And I found evidence that suggests that it's not, that it's statistically smaller. And finally, the last question says, what are the consequences? Does this matter? And I think the last two slides together suggest that this is really important behavior to consider and to keep thinking about. So that displacement and sporadic disbursement of aid does have really negative repercussions for the amount of resources available to governments. So thank you for this, and I look forward to questions.
Thank you very much. Thank you very much. Let me now turn over the floor to Alan Diener to make his presentation on the system of health accounts.
All right, thank you. So I want to talk about deriving expenditure by disease under the system of health accounts framework, which is a way in which we can derive comparable and standardized estimates of expenditure across disease with a specific focus on estimating hospital expenditures. So this is an outline of what I want to talk about. I'll first talk a little bit about the System of Health Accounts 2011, then specifically about the expenditure by disease project on which I'm working. I'll then talk about a model that I've derived in order to estimate expenditures in the hospital sector for countries that don't necessarily have that data available using administrative data. And then I'll conclude with some next steps, both specifically with respect to estimating the hospital expenditures and the overall expenditure by disease project. So the System of Health Accounts was released in October of 2011. It's a joint product of the OECD, Eurostat, and the WHO. And it's a revision of the System of Health Accounts 1.0, which came out, I believe, in 1990. It's a way of tracking expenditures throughout the healthcare system. With consistent methodologies, all OECD countries and other countries contribute and provide data on a regular basis. As I said, it's standard classifications with respect to providers, with respect to financing agents and schemes, and with respect to health functions. And so it's a framework that can follow expenditures as they come into the system and as they go through the system and track them and see what they're being spent on. Yuki will talk a bit more about tracking, which I won't really cover in my talk right now. There's this triaxial relationship, which is at the core of the System of Health Accounts, where there's this relationship between the provision, as I said, so those are the providers. We're talking about hospitals, for example, physicians, outpatient care, financing, so where does the money come from, and finally, how are those dollars consumed? That's the real focus of when we want to look at expenditures by disease. It's where the dollars go to, both from a functional point of view. Are we providing it for acute care, for prevention, et cetera? And can we apply to certain characteristics of those recipients? And that's the real challenge, is how we can allocate it and distribute it by the beneficiaries, by types of disease, by the age, gender, income, etc. And that's where the real challenge lies. So all countries provide data for the system of health accounts. Only for a few countries can we actually allocate it by disease. Now, under this specific project, it was started back in 2008. Some guidelines were produced at that time, providing information on how countries can allocate expenditures by disease under the SHA framework, specifically by diagnostic category. The diagnostic category at the time that was used was the ICD chapter, so there's 21 different categories. It can also be done by IHME, which is the International Short List of Hospital Morbidity Tabulation, but that obviously depends on the availability of the data within a specific country. As we move forward, one recommendation we have is that countries try to compile the data by IHME. It ends up being much more useful as we get more granular and can start looking at specific diseases rather than just a whole chapter, which may cover quite a wide range of different types of diseases. As well, we're trying to get information on a breakdown by age, sex, and socioeconomic status where it's available. Once again, all of this is dependent on what data is available in each country. Now, why is this important? Well, it's important because we can use it as an input in cost of illness type data, and then in things like economic evaluations, trying to link it to outcomes and use it in healthcare policy research. So, for example, we can use it in order to look at patterns of practice across countries. If we can then compare it to outcomes, and if one country has better outcomes, we can see where the expenditures are being spent. Is there more institutionalization? Is there more money being spent in community settings, more money on pharmaceuticals, et cetera, and try to get a good idea of patterns of practice, both changes over time and differences across countries. And the reason we want to do it under the system of health accounts is so that we can have a consistent and standardized approach. And so these are actual expenditures that we're tracking. In cost of illness, we can use bottom-up approaches where we multiply a cost of unit times the number of units. But what we're doing here is we're actually doing it from the top down. These are actual expenditures and trying to allocate them to the specific diagnostic categories. So the first thing that we can do is categorize it according to the SHA functions, which HP is health providers, by HF, which is financing, and HCRR functions. We can then split it up into these different categories, and then this is where the real challenge is then trying to come up with this cost unit specific utilization or allocation key. And that's when we can then sort of force it and split it up into different diagnostic categories. In 2008, when the first guidelines were produced, we did a pilot study when we had data from 6 countries which represent different types of healthcare system characteristics in order to see whether or not this was feasible. How did it work? We also, it turned out that it could work pretty well. Different countries had some different issues, once again, mainly relating to data availability, but it in theory was feasible. Since then, we've been able to get data from some other countries. Some countries produce this type of data on a regular basis. Some are able to provide data just specifically for the project, and those countries are listed here. Now, in the hospital sector, that's where we have the most detailed data, both in the expenditure by disease. Right now, we have data for about 10 countries. And as well, we have more administrative data. As part of the OECD data collection, we regularly collect data from all OECD countries with respect to number of bed days, number of discharges, and average length of stay. So the idea is, well, for the countries that we have the data, we have expenditure by disease data, can we somehow come up with a model that we can then apply and come up with predicted or estimated values for those countries for which we don't have the specific expenditure data by disease data, but we do have that other administrative data. Okay, so now the idea then is we have information on bed days for all countries. Now, we could just use bed days, if percentage of bed days allocated to a certain disease, and use that as our allocation key. That assumes that all diseases use similar resource, so we know that that's not the case. So for example, a bed day, a person in the hospital for cancer is going to use more resources than someone for mental health. And we need to somehow take that into account. So the resource intensity is different across diseases. Generally, for reimbursement methods, DRGs have been developed, and that's the type of data that's generally used to develop the expenditure by disease data that the countries provide. So that's more accurate information on resource use, and it's really, what we're really trying to do is see if whether or not we can come up with an average resource intensity weight across those countries for which that we have that data for, and apply it to the other countries. So we have data on ICD-10 and ISHMT for this group of countries listed below. We have several years of data for some countries. There's potentially data available for other countries, the ones listed in the bottom for Australia, the Czech Republic, Germany, and the Netherlands. For some of them, we may only have ICD-10 data and not ISHMT. That was not included in this preliminary analysis. And so this is the model that I estimated. There's two models where, so I've modeled expenditures as a function of average length of stay and of bed days. And the difference between the two different models is one, the diagnostic category where the ICD chapters, so there's out of the 21 chapters, we have data for 20 of them. The other one is trying to use this more granular data. The thinking behind that is if we dig down and get more granular data, we'll end up getting better results because that'll take into account some of the more differences at a more granular level. There was also variables on country-specific demographic type variables, such as share of public health spending, incidence of cancer, prevalence of obesity, per capita GDP, life expectancy, and physicians per 1,000 population. The idea there is that somehow these would be indicative of the healthcare system characteristics, different treatment, different guidelines. We're going to use some more variables down the road, looking specifically at surgical procedures and differences between day cases and stuff to see if we can come up with explanations for some of the differences we found. So in general, the results were pretty good. Model 2 performed slightly better using that ISHMT level data, but not as much better as I would have necessarily expected. For the demographic variables, only the prevalence of obesity and physicians per 1,000 population were significant, but generally the results worked well for most ICD chapter totals. So now here we have results for all the ICD chapters. This is just Canada. I just have results. I'm going to show you results for just 2 countries for 1 year for each country. And this is if we use comparing bed days versus expenditure by disease as our allocation key, what some of the differences would be. So if you look at, for example, on mental health, if we use bed days as our allocation key, we would overestimate expenditures, and that's what we would expect. For circulatory diseases that are more resource intensive, we would be underestimating it. So that's comparing that blue bar to the red bar, and we see the same thing in Finland as well. So the things are looking the way we would expect them. Now, how did our model work? So the bars for the two models are the green and the blue, and we can see that we're actually getting much closer to the actual expenditures. So the model does seem to be working well, but we get some quirks in some of the results for some of the countries. So for example, if we look at the ICD code for cancer here, we can see that in Canada that the estimates are overshooting. Okay, so it's not quite working. There's something not quite working well there, but for all the other ICD chapters, we're doing quite well. In Finland, we can see that for births, that we're getting closer to bed days than we are to expenditure. So there's something not quite working well. In general, the results were quite good, but there's some quirks in some areas. So what we want to do is investigate that. So the next step with respect to the hospital analysis is to include more variables, to try to understand what's going on, why are we getting some of these quirky results for some of the countries, for some of the specific ICD chapters. We're going to add variables on surgeries and procedures, look at things like readmission rates and day surgeries, because we may be capturing things where there's certain more difficult cases being admitted, and we want to get a better understanding of specific diagnostic categories. There's the issue of using multiple years for some countries, which is going to bias the data, so we will probably get rid of that and use some sort of moving average. We also want to add data for more countries. We have more data if we can restrict it to just the ICD analysis. There is data available for more countries. And the idea then is now to use the proposed model or the refined model to derive expenditure by disease data for all countries. Finally, with respect to the overall expenditure by disease project, the next step is to finalize the guidelines. As I said, the guidelines were produced in 2008. There were some outstanding issues that we're going to provide some recommendations for. And the goal is to ultimately end up with an expenditure by disease database, starting with about 10 to 15 countries. So as I said, we have data for about 10 to 15 countries. For some countries, we have data across the entire system. For some, we only have hospitals. We have different levels of granularity, perhaps IHME for some, ICD for the others as diagnostic categories. But the idea is to start the database somewhere and start building it, showing how this data can be used, and it already has been used in some reports, looking at things like mental health and at NCDs, but try to get it to grow and get more countries involved over time. In the areas of primary care and pharmaceuticals, we're still trying to collect more data there. That's the area where it seems to be more challenging. And there's a final report which will be released at the end of 2013. So thank you for your time. If you want more information, you can go to that link there where you can download both the guidelines and an interim report which covers some of the stuff that I've talked about. And as I said, there will be a final report released at the end of 2013 covering this. All right, thank you.
Rouselle Lavado now will continue on a different perspective on national health accounts with this review from 1990 to 2010.
A total of $6.5 trillion was spent by all countries in the world on healthcare in 2011. Where did those money go? What was spent? And who financed them? These questions prompted our team to conduct a systematic review of the national health accounts. This is an ongoing work with the health financing team of the Institute of Health Metrics and Evaluation. My presentation will be organized as follows. I will be starting with a brief overview of what national health accounts are, and then I will answer 3 important health financing questions. Where are health resources coming from, or who is the source of fund? Where do the resources go, or where was it spent? What kinds of goods and services are being purchased? And I will end with some concluding remarks and some next steps for our research. So the national health accounts are a systematic, comprehensive, and consistent monitoring of resource flows in a country's health system for a given period of time. It started as early as 1963 in the work of Abel Smith, and various OECD countries have started tracking their health expenditures over time. As mentioned earlier by the previous presenter, in 2000 they came up with a system of health accounts manual to standardize the tracking of resources for health. And in 2003, WHO and the World Bank came up with a manual to make it possible for low and middle income countries to track their resources for health. And this manual was updated in 2011. So a typical NHA has the following tables: the financing source, financing agent, and health function. And I will go through with some detail later in my presentation. Other tables of the NHAs are provider tables, resource tables, and the beneficiary table, which tells you where the resources are going to. So the underlying data of an NHA is typically compiled from various sources, which are coming from the Ministry of Health, the Office of Statistics, claims databases, surveys from households, providers, and many others. And most countries are producing the NHAs on their own or with the help of some consultants from more experienced countries. So what we did in the past 2 years is to compile all possible national health accounts that is currently produced in the world. And we came up with 125 countries with 934 country year reports from 1990 to 2010. Our team compiled this database and formatted them to align with the system of health accounts framework so that we could come up with, look at some trends, which I will be presenting later on. The map below will show you the availability of NHAs in the world. So the countries in blue mostly OECD countries, are the ones who have been producing NHA religiously all throughout these years. And in some countries, such as those in red, NHA exercises sometimes are one-off exercises, and some middle-income countries have some institutionalization of NHAs. So the first question that we wanted to ask is, where are the health resources coming from? This is a compilation of the NHAs that I have mentioned earlier, and at the x-axis, we group them into income groups of countries. We follow the World Bank definition of low-income, middle-income, and high-income countries. And for the purposes of this presentation, we group them into 5-year bands, although we do have the data at the individual years. On the y-axis, we have here the proportion of the total health expenditure. So allow me to highlight this. In the low-income countries, we see an increase in external funds for these countries. And this is consistent with what was presented by the first presenter, that there has been an increase in development assistance for health in the past decade, especially for low-income countries. Now, for middle-income countries, this is quite interesting, at least for me. There has been a contraction in private funds as source of health, and the public funds has been increasing, whereas the opposite is true for high-income countries. Allow me to pull up one country example. This is Namibia, which has one of the longer series in our collection. And you could see clearly here that in 2004, the share of external funds has really increased. So where is the money spent and where is it going? This tells you the financing agent table, again organized by income classes. And what you could see here is, for low-income countries, this is an interesting research question. OOP has actually increased after 2005. So that's out-of-pocket payments from households. And two stories could come out of this. Is it because that more people in low-income countries are actually accessing care? That's why you have higher out-of-pocket payments? Or is it because prices are increasing? That's why, as a share, there is also an increase. This is the trend for middle-income countries, wherein we see that general government has actually been increasingly spending money on their health systems. And this is consistent with what is happening in the past 2 decades in middle-income countries. Middle-income governments has been implementing various reforms on health systems, such as decentralization and social insurance reforms. For high-income countries, there really isn't much change on the composition of their health expenditure over the past 15 years. Again, going back to the case of Namibia, this is how their health financing agent table looks like. And allow me to highlight one important thing, which is basically an important finding of this exercise that we did. So if you could see, from 2006 to 2007, there appears to be some change that happened there. And well, what we looked at what really happened in the system, and we couldn't find any health reform that went on. So turns out that there's a difference between the out-of-pocket payment estimation because of the difference in the survey that was used. So before 2006, it was the World Health Survey. In 2007 onwards, is the Household Income and Expenditure Survey of Namibia. And so when you have, when you're able to compile data like this and put them side by side, you'll be able to see, do we believe that it really is a change or a change in methodology? So what kinds of goods and services are being purchased? So this one will tell you the different kinds of services or functions in the health system where the money went. So what did it go to curative care? Did it go to ancillary services, public health services, administration and insurance? And for low-income countries, you could see there has been a decreasing trend in curative care and an increasing trend in public health expenditures. But what for me is interesting is the increasing share of retail pharmacy. And this could again point out to an interesting research question as to whether there has been, why are drugs not being dispensed inside a facility? Why is the share of retail pharmacy growing in low middle income countries? For middle income countries, I have mentioned this earlier, and again, this is evident in this figure. There has been an increasing share of health insurance in these systems, and as well as public health. And for high-income countries, again, not much change in composition over the past 15 years. And so what we noticed is that the more mature health systems are, the less changes that you could see really in their health systems over time. So for some countries, they report a granular disaggregation of public health expenditure. So let me just show you the low-income country wherein you could really see that there is a clear increase in the share of maternal and child health expenditures as a percent of public health from 2005 onwards. Going back to my country example of Namibia, here you could clearly see the increasing share of public health over the years, as well as the share of health insurance in Namibia. So this is, we are very much scratching the surface of the trends that we could see in this compilation of NHAs. And much work needs to be done as to how we could make it more comparable, to check for some inconsistencies that we could see in every country. But allow me to end with some very interesting uses of NHAs and why it is important. So with NHAs, we are going to be able to answer very important policy questions, such as, for example, for countries in Africa, how close are they in achieving the Abuja Declaration of spending 15% of their budgets on health? We could also use the NHAs as a rationale for looking at how fiscal space for health could be increased. In the Philippines, where I came from, NHA was used extensively in the debates on sin taxes, wherein the Congress recently ratified a law on increasing the taxes for tobacco and alcohol, because the NHA shows that OOP has not been decreasing and the government share on health has been shrinking over time. And when combined with other data such as utilization, NHA is very useful for example, looking at the functionality of referral systems or conducting benefit incidence analysis on the subsidy of government on health. So, as my last slide, let me show you the future research that we aim to do, because it's not really where the money is being spent, but it's important if we could relate the expenditure on the burden. So the group is going to examine further the relationship between the two. Thank you.
Thank you very much. Our next speaker is Yuki Murakami. Again, we'll be tackling another angle of the system of health accounts.
Thank you so much for the introduction. It's a great honor to be here and be able to present some of our new work on resource tracking in health. What it means, resource tracking in health, is, as we already discussed in the previous presenters, that this is about tracking external resources in health in developing countries coming from donor countries. Before beginning, this is actually our new area of work in our division, health division at the OECD, which might be surprising for some of you because the OECD has a data based on creditor reporting system. However, this is being managed by different directorates, and this is the first time to try to link it between our database on system of health account and the creditor reporting system. And just wanted to mention before that a credit goes to David Morgan, who's the head of the database on the system of health account in our division. So why are we interested in tracking resources? So starting to talk about, first talking about health financing in developing countries, developing assistance for health still plays an important role. And for example, in Africa, 10% of the health spending comes from external resources, and that percentage goes up to 16% and plus among for low-income countries. And so for low-income countries, it is quite important for them to understand the trends in funding flows for the budgeting purposes, as well as health financing sustainability. And for developed countries, and especially for OECD member countries that play a donor role in many of them, it's important for the accountability and understanding where this money is being spent. And this presentation focuses on to show the first preliminary results of how external financing resources for health are being mobilized, managed, and ultimately used. And I'm using, this presentation is based on two databases. One is the system of health, the creditor reporting system, which is the OECD managed database on donor disbursement statistics, and by using the system of health account frameworks. Like Alan already mentioned, that this is being jointly managed by WHO, European Observatory, and OECD. And in order to develop the theoretical linkages and a mapping between the two systems to track foreign resource aid assistance through the health system. So in the next couple of slides, I'm going to explain what we wanted to achieve by using and actually linking these databases, and then followed by a country case study of Kenya to show some empirical evidence. So what can actually help health accounts help? In order to track the flow of health system, resources from sources to use. So SHAR data is to provide the detailed information of health spending by different components, such as providers, functions, and schemes and agents. What it means by that, so this arrow, the diagram on the slide, shows the direction of how a country collects revenues to finance health, to ultimately deliver healthcare services to beneficiaries, starting with financial revenues, how the countries collect revenue, which would be purchased by service providers, including government, and that goes to the healthcare providers with some inputs such as workforce, medical goods, and pharmaceutical, to the actual delivery and provision of healthcare to the beneficiaries. And all these steps can be linked to a dimension of a system of health account. System of health account, we already talked about, has been revised in 2011, and one of the two major features of the revision, one was the disease account feature, and the second is to be able to track the root of total foreign resource flows in the domestic healthcare system. So I'm just going to show you this diagram, which is you see the ROW, which stands for rest of the world, and this is exactly the external funds come from. Has a few ways of channels to actually spend where the funds actually go. So the external funds, rest of the world, can support through global budget support to government, which eventually goes and transferred to different financing schemes, or the external funds can go directly transfer to finance different variety of schemes. And one more important feature of this revision is to allow to link with the the CRS statistics. This gives you the description of how the channels are, and just note one additional important feature is that System of Health Account 2011 framework can actually track loans as an additional item, which has an important policy implication because many of the developing countries still receive loans to finance their healthcare programs through multilateral agencies such as World Bank. This is another breakdown, even the more detailed breakdowns of foreign flows in a SHA framework 2011 shows how the allocations can be made. For example, some of the external funds can be allocated through in-kind technical assistance or in goods. Now I'm going to talk a little bit about the CRS. The OECD Development Assistance Committee tracks bilateral and multilateral donors' aid and other resource flows to developing countries, both at the aggregate level, but also at the level of particular aid programs through the creditor reporting system. Now the data can be categorized by donor country, recipient country, and programs. However, we do know that there are some limitations. For example, because this is based on we call it DAC member countries, so many of them are OECD countries, and some of the key players in this field, such as China, are not included, or some private donors or foundations are also not included in a database, so this does not give a complete picture. And also CRS has a limitation because some of the non-earmarked aid for health is not included, which means the global budget for health cannot be distinguished. Like the System of Health account, it has more, we can break it down by programs. So there are three major components on health: basic health, population policies, programs, and reproductive health that can be broken down by sub-programs, including medical research, basic nutrition, infectious disease, basic infectious health education, malaria control, tuberculosis, bronchial, family planning, etc. This is the chart. I'm going to just give you an overall on the CRS system. As this shows the aid to health by commitment from 2000 to 2011, shows very clear sign indication of how the prevention money and what the external funding to prevention increased over years between 2000 and 2011, seeing about 50% of the share was spent on prevention that went to 2/3 in just about 10 years. And this corresponds to the reason of the MDG and the launch of the global funds and the Gavi and so on. This here gives a mapping of how CRS is linked to System of Health account. You see that each program of CRS can be categorized according to the System of Health account category. So the dark green shows the System of Health account. And for example, I'm taking one example of curative care in System of Health account can be linked to basic healthcare and health personal development in a CRS. And you see the noting that the dominance of prevention and population health by program level detailed. And certain programs are mapped to capital spending categories. So for example, gross fixed capital formation is linked to basic health infrastructure, but this is outside of main health spending total. So how do we actually track resources? So we use the one data set, which is the CRS, and other sources such as country reporting on donor development assistance for health. that would give a complete or relatively complete picture of the development assistance for health. And this is, within the framework of System Health Account 2011, we're breaking down by financial revenues, and that goes either to health expenditure level data, such as aid funding for health services and goods, or memorandum items including loans, capitals, research, training. And we worked on the data by type of care, so including care, primary care, inpatient or pharmaceutical, and by disease level data, so including maternal and child health, so tuberculosis, HIV/AIDS, and so on. And then lastly, we have data on capital, including physical, R&D, and human resources. I'm going to show you an example, a country example of Kenya at the aggregate level. So here the title says Kenya shows a convergence in different channels of AIDS estimates. What it means by that is the chart. On the left-hand side shows the total health expanding. So you see the red bar is the donor funding, and from 2000 to 2001, 2002 to 2009 and 10, the donor funding increased to 34%. And on the right-hand side shows the total donor disbursement and spending, and that shows and then also the lines, the red line is the national health account in Kenya, and the two lower lines show the data from the development assistance for health at the IHME and the CRS from the OECD database. As you see, that large gaps existed for the estimate of external funding for their fiscal year 2001 and 2 and 2005 and 6. However, the gap decreased for 2009 and 10 data, implying better data quality in donor agencies reporting and NHA estimates. So we would like to say that consistency between AIDS statistics and health accounts actually improving in theory. However, it's also rational to say that maybe it's by coincidence, because Kenya National Health Account is very well established, and this is the third or fourth round of their data collection. And I'll show you why, because of the sub-accounts also shows quite consistent data. So the one in orange shows the CRS program data for Kenya, and the one shows the actual, the blue. So the one on the right-hand side shows the expenditure by disbursement from the Kenya National Health Account data. And I will just take one example of malaria control. According to the CRS disbursement, the external funding funded about $72 million for the fiscal year 2009-10, which is quite similar to the actual recording of spending in their national health account. However, we still have remaining challenges, so we always need to link different data sources. And for example, in the WHO American region, most of the official reports of external funds include China, and obviously in most cases, the actual amount reported is a bit larger than the one in OECD DAC CRS database. And the capturing of foreign revenues in the health system is difficult because of the fact that CRS does not capture the non-aid earmarked to health purposes. And then also timing of disbursement and expenditure might be different. For example, System of Health Account records times of spending but not receiving. Next steps. This is actually just the beginning of our work on resource tracking. First, we are working on the chart 2011 implementation, and happy to report that OECD countries, as well as many African and Asian countries, are quite active with the implementation of chart 2011, which enable us to first report the annual report from later this year, and then also continue to work on country case studies on resource tracking. In terms of the actual case studies, we are going to complete this report by the end of this year to be able to publish. And then also we're working with WHO to carry out training courses and as well as a symposium on system of health account. Thank you very much for your attention.
Thank you.
Our last presentation is by Gabriela Flores on the very important topic of catastrophic health expenditures.
Thank you for giving me the opportunity to present this joint work with Owen O'Donnell. We are actually both involved in a collaborative research project which focuses on health equity and financial protection in Asia. And within this HEFPA project, we are looking here at the financial risk households are exposed to because of healthcare expenditures. Health expenditures are indeed a major threat to living standards in countries, in low income and middle income countries in which there is low health insurance coverage, but also in high income countries in which healthcare is mostly financed through out-of-pocket payments. Insuring against medical expenditure risk is widely perceived as one of the main goals of a health system. And one of the main metrics used to assess financial protection is simply looking at the proportion of income that is used to pay for healthcare. Now, when this share is high in relation to some arbitrary threshold, these expenditures are believed to be catastrophic. So the incidence of catastrophic payments is then used to compare countries in relation to their ability to insure households against this risk. Now, there are many problems with these measures, but I'm just going to focus on two here. We believe that a measure of financial protection should focus on the prospect of contracting an illness that would require spending on healthcare to such extent that the household living standard will be threatened. And the prospect of this risk are not necessarily observed in the time period in which you're using to evaluate financial protection. So the current measures actually focus on households that do incur such a high level of expenditures in the year you're using to evaluate financial protection, but you may have more households that are exposed to this risk and that are lucky not to have incurred in the year you're using to evaluate financial protection. So we believe that financial protection should take an ex ante perspective and not only an ex post perspective. The second limitation these measures have is that they're using a threshold that is arbitrary. What we're going to do is to focus on measuring medical expenditure risk. For that, we're going to focus on exposure to bad prospect. The bad prospect would be the risk of households' living standard being reduced, possibly to subsisting levels. And we're going to derive measures using reference-dependent utility models with loss aversions. These measures would be decomposable, and we're going to apply these measures to 7 Asian countries using the World Health Surveys, which are cross-sectional surveys. And what we actually find is that the risk is the highest for households with low income, with low levels of wealth, with low levels of education, with lack of self-insurance or poor access to informal insurance networks, and with chronic illnesses. We also find that among the countries we observe, the risk is highest in Laos, in China, and is lowest in Malaysia. So what is the framework we're using? We are assuming that out-of-pocket health payments are uncertain, but the ability to finance out-of-pocket payment is not. So even in low and middle-income countries, households do have precautionary savings that they keep to pay for healthcare. They also have a network of relatives or friends that they can rely on to borrow in case of needs. They may also have some assets they can sell to pay for healthcare, and they may be able to borrow from informal money lenders, even if it's at very high interest rate. So the ability to finance out-of-pocket payments is not uncertain. They can also rely on their income, and the income, we assume that it's also fixed. So they know how much they can use, how much income they have to pay for healthcare. Within these assumptions, we assume that spending $1 on healthcare translating to spending $1 less on the consumption of non-medical goods and services. And we also assume that the utility of the household depends only on the consumption of non-medical consumptions, goods and services, because we believe that that healthcare is largely non-discretionary. So within this framework, a large draw in out-of-pocket payments, which is the first graph you have on the left-hand side, translate into a low draw in non-medical consumption. And the household evaluates the level of satisfaction he feels when consuming a given amount of non-medical goods and services, not only based on the absolute level of consumption, but also in relation to a reference point. Now, given this reference point, so given this reference point that is highlighted in red, the household particularly dislikes consumption levels below this reference threshold. And he dislikes much more consumption draws below these reference points that he would prefer consumption draw above this reference point. So under our assumptions, consuming healthcare means sacrificing consumption of other goods, and because out-of-pocket payments are uncertain, the consumption of non-medical goods is also uncertain, and we're going to use this reference point to evaluate the expected loss due to out-of-pocket payments. So this measure of risk is a measure of downside risk because we're only looking at risk below the threshold, and it can be decomposed into the probability of consuming less than the reference point, but also into the loss due to predictably low levels of consumption below the reference point and the variability below the reference point. So we illustrate these measures using the World Health Surveys conducted in 2002 and 2003. These surveys are representative for all the countries listed here except for China and India. The sample size vary between 4,000 and 9,000. And the World Health Surveys have a lot of information on out-of-pocket payments, sources of financing for healthcare, chronic conditions, socioeconomic and demographic indicators, and also on non-medical expenditure. So to apply our measures, we need to simulate the distribution of out-of-pocket payments that the household face. And to do that, we use quantile regressions, but we condition on households not using coping strategies, not using informal insurance arrangements. And we do this because we are interested in the medical risk that is affordable, albeit by duress, but not on the risk of needing a healthcare that is unaffordable. Because the risk of needing healthcare that is unaffordable is a health risk. It's a risk on the health status and not a financial risk. So we use these quantile regressions to simulate the distribution of out-of-pocket payments for each household. We also predict the level of income each household has. And we, therefore, under our assumption, simulate the distribution of non-medical consumption by subtracting out-of-pocket payments from the fixed level of income. With these measures, then we need to assess the reference point, and there are two possibilities. Under reference-dependent utility models, the reference point should be internal to the household preferences. So we take the expected level of out-of-pocket payments, which under our assumptions translate into the expected level of non-medical consumption. But we also use an income-related threshold because this is consistent with the current approaches, but also it is consistent with the theory on health insurance. So what do we find? We find that risk is lower, the risk of medical expenditure is the highest for households that have lower levels of income, although not in Philippines, but there is no obvious reason for this result. We also find that the risk is highest for households that have less recourse to informal insurance arrangements, but not in Laos. And let me emphasize here that in Laos, actually, we observe the lowest proportion of households relying on informal insurance arrangement to pay for healthcare at all levels of the out-of-pocket payments distribution. We also find that the risk is highest for households that have lowest level of wealth, again, not in Laos. Risk is also high, very high for households that have at least one member suffering chronic illnesses. It is highest for households with low education level, but not in Bangladesh and Malaysia. And it is highest when there are more members in the family. We also observe that the risk of medical expenditure is lower in those countries that have mandatory health insurance, which are China and Malaysia, and the risk is substantially lower for households that have those health insurance by 80 to 90%. The probability of spending more than 20% of household income ranges between 3 and 70%. It is the lowest in Malaysia and the highest in Laos, and the variability or the uncertainty in out-of-pocket payments accounts for more than 80% of the medical expenditure risk. So one thing that I should have mentioned is that Malaysia is actually the country which is the closest to achieve universal coverage within the range of countries we are looking at. They have a tax-based health system, and they also perform very well in targeting subsidized healthcare to the poor. By contrast, Laos has a very low level of health insurance coverage and performs very poorly also in terms of targeting the poor. China, in the year we are observing, the rural areas are largely not insured. And in the Philippines, there is a national health insurance program, but it only finances 9% of total health spending in the years we are considering. So, keeping these features in mind, we find that the countries in which the risk is the highest, the medical expenditure risk is the highest, is in Laos. It is the lowest in Malaysia. This is consistent with the way the health systems are built in these two countries. We also find that in the Philippines, despite having a national health insurance program, risk is not significantly different than the risk in the other South Indian continent countries. And we then compare our ex-ante measures with the ex-post measures, which are the incidence of catastrophic payments, and we observe that ranking countries based on the exposure to medical risk versus ranking countries looking at the incidence of catastrophic payments, it's not the same. In particular, Pakistan, India, and Bangladesh perform worse in terms of the incidence of catastrophic payments, and this is largely driven by the fact that in these countries, out-of-pocket payments are largely predictable, whereas in the other countries, they are less predictable. So to summarize, we propose measures of downside risk from medical expenditures. We believe that these measures are appropriate to evaluate the benefit of introducing a health insurance. These measures capture variation in exposure to risk at the household level. They are more informative for targeting, for instance, and so we believe there is a value added to adopt an ex-ante approach.
Thank you very much. Great. We've heard 5 excellent presentations with a very interesting mix of innovative measurement strategies and of course, huge substantive relevance in terms of not just advancing the understanding, but also huge policy relevance. So we have a few minutes for questions. There are 2 stationary mics on each of the 2 sides of this room. So if anyone has a question, please go to one of the mics and ask your question, please, here on.
Hi, I'm Bob Emery. I'm with USAID's Health Systems Office, and I've worked for the last 20 years on developing our National Health Accounts Assistance Program to work with the folks that you've been getting your data from. In the conversion countries are making now to the SHA 2011 process, we are again having to open discussions with ministers of health and ministers of finance as to why we should be doing national health accounts. And in some ways, we're having to make a different case than we did before because the process is somewhat different and in some cases somewhat more complicated. So what is your best advice, your best shot at the elevator speech to the Minister of Health as to why to convert and quickly to convert to SHA 2011?
We're going to take a few questions, so please keep track of the questions. They're all very important, but so that we can finish on time, we'll take the remaining questions, and then I'll ask each panelist to address whichever they prefer to do. So please, on this side.
Hello, I'm Diego Rio Sertuche from the Mesoamerican Health Initiative, Inter-American Development Bank. So my question is mainly for the first and fourth speakers, because your topics are very related to what we want to know. So the first one is, if you have looked into the behavior of replacement and displacement at the subnational level. Many donations are targeted to particular areas, and it will be very important for us to know whether these donations are displacing government funds to these areas that are many times the poorer. A related question is where the funds are being spent, because the funds many times go to infrastructure, equipment, training, and the most important is perhaps capacity development, because that stays in the country after the donor leaves. So the related question to that is, how is this affecting the performance of the system? Thank you.
The next question on the...
Thank you. George Patton, University of Melbourne. Look at these great presentations, and I was particularly interested in this concept of the universe of health financing, and that's important. Prevention is my question, and where prevention sits within that universe. So it's a question, I think, for speaker number 4. Some things do sit in terms of prevention within healthcare. So bed nets, vaccination, they sit clearly within healthcare. But if you're looking at areas like prevention of injury or prevention of NCDs, many things sit outside the healthcare delivery system. So if one's looking at tobacco control, prevention of road traffic injuries, even education about sexual and reproductive health, these things are sitting outside of healthcare. So are we counting them? And if we're not counting them, who is?
Great. Let's, I'll ask the other questions to stay there. We have time for you, but because attention span is limited, let's take these first 3 questions, and then we'll go back to you. So don't give up on your question. Anyone wants to tackle the first one? I mean, we had 3 presentations on the systems of health account, the system of health account. So who would like, maybe our colleagues from OECD, have some insights?
I'll try to tackle the first question on why to convert to SHA 2011 and try to convince countries. I guess as more countries are starting to go that way, we're getting better information, we're getting more standardized results and standardized data. There's better ways of tracking finances through financing agents and schemes through the SHA 2011. If we can have better resource tracking, a better idea of where the dollars are going, and if they're going where they should be. So I think if we can ultimately be able to tie the results and follow the resources and ensure that money is being spent in the areas that we want it to be spent on, the SHA 2011 is one way that we can do that. And if we can then compare the results across countries as more countries are coming on board, we'll then ultimately have more consistent comparable data. So I would suggest that as one reason why you'd want to switch to SHA 2011, just for more granularity and better comparable standardized data that we can track over time.
What about the elevator speech? How do you convince the Minister of Finance and the Minister of Health that this is important to do? And anybody else who wants our three middle panelists who talked about this. What's your elevator speech? Why should they spend resources tracking all of this and measuring? Go ahead.
Okay. I'm not sure if this is going to be the elevator speech, but from my perspective and the person working at the OECD, I see this is a great opportunity. Not because of the fact that we worked on it, it's because it's the new system. It has a better categorization of some of the features that were not addressed in the first version, and especially for the financing agents and financing schemes, that really categorizes better and responding to the new wave of a new era in the global health financing time. And as a person, I think as a person working on this, I think there's a lot more can be achieved and addressed to the global community on how important it is to have a standardized health accounting system that addresses not just from the donor perspective, but also from developing countries' perspective, to show that this is what we are doing this, and we have a transparency and accountability, but at the same time can focus on sustainability of health financing.
Good. Let's go to the next question, which pretty much was addressed to you, Joseph.
Great, thank you. So the question was about subnational displacement and replacement, and there's research that has looked at all different types of fungibility. My work has looked specifically at this intersector, so the transfers or the displacement from the health sector to education or defense or so on. The work that has been done to look at maybe within the health sector, so the intra sector, is limited and more likely to be case studies. And I think the real reason for that is not interest or policy relevance. Those are certainly really important questions, but it's data reliability. So there's not a ton on that, but I think there's a need for more data and more research there. And then the second part of the question was a little bit about where are those resources going, and are they building potentially infrastructure such that a short-term shock of more resources would be good? And again, I think it's more or less the same answer. There's not a lot of data on this. So to track where the resources are being displaced to is very difficult. But I think it raises an important question that says, where are they going? And this is something we should be thinking about. Is the shock financing vaccinations or new hospitals that are really short time possible and really beneficial in the short run? And again, I don't have a good answer for that, but I think more data and more research is needed.
Thank you. Anyone wants to tackle the last question on all these very relevant issues that might fall out of healthcare strictly defined, but is someone else measuring that? Rouselle, would you like to?
So I think in the SHA 2011, it can accommodate things like that if the government is interested on that. So you'll be able to look at below the items. So if the government is really interested, for example, on looking at how much is spent on water and sanitation, and usually it's outside the Ministry of Health, but they would like really to know. So there is below the item, memorandum item in SHA 2011 that will allow that. And if I may expound on the elevator speech on the Ministry of Health, yeah, indeed, it's very, very difficult to convince, I understand your question, to convince countries that have spent a lot of effort understanding the O3 guideline to shift into 2011 is really difficult. And I think at least the way we did it in the Philippines, is to convince the minister that with the new SHA 2011, we'll be able to answer the questions that he's been asking us, but there really is no answer to that because we can't track it with the system that was in place before. I think that's a compelling argument for the SHA 2011.
Thank you. We'll take the last two questions and then we'll have to wrap up, so please go ahead.
Great. Thanks very much. Peter Hansen from the Gavi Alliance. Thanks to all the presenters for very good and interesting presentations. I have a question for Joe about the replacement of displacement or replacement effects. I'm wondering to what extent you've had a chance to disaggregate the analysis by type of development assistance for health, because the analysis at a very high level collapses lots of different types of development assistance for health, which in different types that may have very different characteristics. So I think one distinction of interest, for example, is cash support versus commodity support. The effects in terms of displacement or replacement may be very different. That's just one example. There are also other distinctions. I'm wondering to what extent you've had a chance to look at that. Thank you.
Do you want to ask your question? And then we have a last one here.
Sure, great, thank you. I'm Sarah Pallas from the Yale School of Public Health. And my question is with regards to this issue of the timing between disbursements and expenditures, and this being a tricky thing to figure out when we're linking CRS to the system of health accounts, and when a lot of our modeling may depend on exploiting this country year level variation over time series. So I know it was referenced as a limitation, and I'm just wondering among the panelists, what you've used in your own modeling approaches, what assumptions you're making so far in your efforts to link accounts or in your own modeling and estimation in terms of the lag or in terms of how to link these disbursements from donors and from creditors to the actual expenditures by government. So just what approaches you've used so far, what assumptions you've made, and any recommendations you have for people who are trying to look at both the disbursement side and the expenditure side. Thank you.
Great. And then Professor Lozano will have the last question.
Rafael Lozano, thank you very much for the great presentations. We took around 20 years to collect 125 countries for national health accounts. I mean, we don't have more countries. Now you are proposing a new system, SHA 2011. How long do you think that will take? And what is the purpose to make comparability in order to help decision makers? It is any switch to health information system take a big responsibility for those people that propose and for those that are going to use. So what is your recommendation following the idea to, I believe that this is an improvement. No one recommends something that is going to be worse, but this is, are you considering how much will cost for all the countries to do this, how long will take, and what is the skills they need to do this? Thank you.
Good. Let's take the, you want to start?
Yes, no problem. So the first question directed towards myself was about decomposing different types of aid and looking for different effects. And the real simple question is, I have not done that. It's not something I'm not interested in. It's something we've been thinking about, but certainly there's probably heterogeneous effects across different types of aid, different diseases that projects are targeting and whatnot, and that's ongoing work, but nothing ready yet.
On the other, the next, Yuki, I think this was pretty much inspired by your presentation, so.
Okay, so I'm gonna first answer to the question from Sarah on the assumptions we made between disbursement versus commitment. I didn't include it in our slide, but we did first analyze the data by disbursement and realized that was absolutely not comparable. And we also know by the fact, and also from my working experience at the different institutions at the World Bank before my OECD time, that many countries actually sit on the money, not using it for a long time and not being able to use it because of the capacity or because of some legal, but some of the political reasons. So our conclusion was to use the commitment data. I mean, not using commitment data, but the disbursement data, and it turned out it has a better result across national health account and our creditor reporting system. referring to the Professor Raffaello, I think one thing I can actually say is if there is a doubt, please come to our training sessions on System of Health Account 2011, because that's when we're actually able to exchange information, but as well as experience from different countries. Everyone has a doubt on why we're doing this, especially when it comes to a new framework. And I understand the limitations and capacity, the human capacity as well as technical capacity, being a challenge in many of the countries, not just developing countries, but many of the OECD countries. However, the OECD mandate is to translate evidence into policy making. In order to do that, by doing that, we do a comparative analysis across different countries. And that gives a very good picture, transparent picture of how the money is being spent on such items such as in curative care versus outpatient. And we do see, because many of the countries still rely and should rely on, or do rely on public health schemes, we do see how the importance is over the years, as well as how the different components are mattered in budgeting purposes as well as policy making. Thank you.
Thank you. Well, let me close the session by thanking our presenters. As I say, I think we had a very interesting example of what we're here for, to both listening to innovative measurement strategies with around topics of enormous substantive importance. Although there were some commonalities, obviously in the use of certain sources, there were also different angles of this very complex issue of health financing. But I think the common thread is the need to not just measure correctly the flows and track them, but also to understand the effects of health financing, which I think is becoming increasingly important as we've gone through this era of expansion of financial resources going into health systems. Both, of course, this enormous growth during the first decade of the 21st century, and although, as Joseph was suggesting, this we may have reached a plateau level, we don't know yet, but certainly we have seen a huge increase. But more impressively is the growth in domestic expenditures, which is likely to continue given the demographic and epidemiological transitions underway. So understanding the complexities and not just tracking the volume, but also understanding the effects of financing is important, because financing is not just the enabler of every other intervention, it is itself an intervention. And it also illustrates a way of demystifying the idea that health systems are sort of black boxes that we don't understand exactly how they operate. I think you've gotten a glimpse with these set of excellent presentations of how we can actually open the black box and understand some of the, not just the movement, but the potential effects of different ways of financing this growing sector of activity, which is the formal health systems. And of course, the conclusion is that there are better and worse ways. I think the last presentation by Gabriela Flores reminds us that protecting people from the financial consequences of spending in health is itself an objective of a health system. And therefore, understanding those effects, I think, has become crucially important as the volume of resources grows. It also will be a fundamental part in any effort at accountability moving forward in the post-2015 era. So please join me in thanking our 5 panelists today. And there will now be a break, and we'll reconvene at 4 p.m.